A very good morning to the respected Chairman Emeritus, Sir, President Vice Chancellor, sir, and all the respected senior faculties and my dear colleagues. On the behalf of the Department of Obstetrics and Gynaecology, Mahatma Gandhi Medical College and Hospital, I welcome you all to the session of Clinical Combined Rounds. I, Dr. Smit Thummar, a second-year PG resident from the Departments of Obstetrics and Gynaecology, am going to present a case on 35-year-old female with recurrent pregnancy loss, a mother's journey. We have a case of Mrs. X, 35-year-old Hindu female, graduate and nursing staff by profession, belonging to the upper middle socio-economic class and a resident of urban area of Jaipur, presented to the Mahatma Gandhi Hospital on 23rd of December 2024. With history of 2 months of amenorrhea, complaints of nausea and vomiting on and off since the last 2 days, with a positive urine pregnancy test. The obstetric history: she had a history of non-consanguineous marriage at the 22 years of age with an active married life of 13 years. She was gravida 11, para 1, live 1 with 9 abortions. In the first 3 pregnancies, she had 3 spontaneous abortions at 6 to 8 weeks gestation, wherein the ultrasonography was suggestive of a blighted ovum. All these 3 abortions were medically managed. In the next 3 pregnancies, she had 3 missed abortions at 8 to 9 weeks of gestation, wherein the ultrasonography was suggestive of missed abortions. 2 were managed by dilatation and evacuation. 1 was medically managed. In the 7th pregnancy, she had another spontaneous abortion at 6 weeks of gestation, wherein the ultrasonography suggested no gestational sac to be seen, and ultimately labeled as a biochemical pregnancy loss. In the 8th pregnancy, that is in 2019, she conceived spontaneously. At 34 weeks of gestation, she underwent a preterm lower segment cesarean section, the indication being preeclampsia with severe features and placenta previa. Delivered a female child of 2.3 kg who is now alive and healthy. In this pregnancy, antenatally, she was on antihypertensive medications. In the next 2 pregnancies, she again had 2 spontaneous abortions at 7 to 8 weeks of gestation, which were both medically managed, with the last abortion being in May 2024. In the 11th pregnancy, that is in October 2024, she conceived spontaneously, which is the current pregnancy. She had no history of any genetic testing of the abortus in any of these pregnancy losses. The parental karyotyping was normal, done outside at an outside center in 2015 after the 4th pregnancy loss. However, no documents were available at the time of consultation. She had no history of anti-phospholipid antibodies testing in any of these pregnancy losses. The menstrual history: she had in menarche at 13 years of age, with the past menstrual cycles having normal flow for 4 to 5 days every 20 to 30 days with no dysmenorrhea. The last menstrual period was on 28th of October 2024, and according to Negley's formula, the estimated date of delivery was calculated as 4th of August 2025, and the period of gestation is 8 weeks. In the past history, she was a known hypothyroid since 2013, already on tab thyroxine 100 micrograms once daily. She had history of preeclampsia with severe features in the previous pregnancy in 2019. No other significant medical or surgical history was found. In the personal history was normal and with no history of any drug abuse or excessive caffeine intake. In the family history, she had no history of diabetes, hypertension, any genetic disorders in her family, and no history of recurrent pregnancy loss in a mother or a sister. The husband history was normal with no significant medical or surgical history. Now let's re-encapsulate the summary based on the history we just took. We have a 35-year-old female with 9 first trimester losses, a normal parental karyotyping, a known hypothyroid on medications, history of preeclampsia with severe features in previous pregnancy, for which she underwent preterm lower segment cesarean section at 34 weeks gestation, and in the present pregnancy she conceived spontaneously. So based on this summary, would anyone from the audience like to take a guess what may be the possible cause for the pregnancy loss in our case? Yes. Yeah, one of the causes hypothyroidism for our case. So we have a Mrs. X, 35-year-old female with history of recurrent pregnancy loss, with gravida 11, para 1, live 1, abortion 9, with 8 weeks period of gestation, with hypothyroidism, and with query acquired thrombophilia, that is APLA. Now let's look at the examination findings. She was conscious and cooperative, was efebrile on touch, that is temperature recorded as 37 degrees centigrade. BMI according to the height and weight parameters was recorded as 24.2. The vitals were recorded as normal. In the general physical examination, was normal with no apparent thyroid swelling found. The systemic examination, CNS, respiratory and severe examination was done and was found to be normal. Obstetric examination. In the per abdomen examination, upon inspection, a well-healed phalansteal scar mark was seen, and on palpation, abdomen was soft with no organomegaly, and the uterus was not palpable. Local examination. On per speculum examination, os was closed and cervix and vagina grossly appeared normal. On per vagina examination, os was closed and uterus approximately of 8 weeks size was found. Blood investigations for the patient were done, which were found to be normal except thyroid stimulating hormone, which was grossly elevated to 71.12 microinternational units per ml despite being on the medications. Ultrasonographic dating scan was done, which suggested a single live intrauterine pregnancy, wherein the CRL was suggestive of 7 weeks and 6 days gestation. Fetal heart rate was documented as 150 beats per minute, and the placenta was forming posteriorly. Now, based on the history, examination, as well as the investigations, to summarize this case, we have a Mrs. 35-year-old female with history of recurrent pregnancy losses, with gravida 11, para 1 live 1, abortion 9, with a single live intrauterine pregnancy of 7 weeks and 6 days gestation, with hypothyroidism, and with query acquired thrombophilia, who had a history of preeclampsia in the previous pregnancy. Now, to take a brief look at what is recurrent pregnancy loss and what may be the causes for recurrent pregnancy loss for our case. Citing the worldwide literature, according to RCOG 2023 guidelines, 3 or more first trimester miscarriages or 2 or more second trimester miscarriages, which need not be consecutive losses. According to the ASRM 2025 guidelines, 2 or more failed clinical pregnancies documented either by ultrasonography or histopathology. And according to the ASHER 2022 guidelines, spontaneous loss of 2 or more pregnancies from conception till 24 weeks of gestation, which includes both ultrasonographic as well as biochemical pregnancies, which also need not be consecutive losses. However, this definition excludes molar and ectopic pregnancies. The causes for the recurrent pregnancy loss include anatomical causes, genetic, endocrinal causes, thrombophilias, and lastly unexplained causes. In the anatomical causes, we have uterine causes and cervical causes. In the genetic causes, we have aneuploidy and translocations. In the endocrinal causes, we have hypothyroidism and diabetes mellitus. In the thrombophilias, we have inherited thrombophilias and acquired thrombophilias. And the last
mainly for the obstetrician, anatomical causes are responsible for the second trimester, mainly, not for the first trimester. Okay.
So based on the ultrasonographic as well as the history-based evidences, we have ruled out uterine as well as the cervical causes.
So the fact that she's had one normal delivery or cesarean delivery, one alive baby,
yes, sir.
Can you rule out anatomical causes because of just that normal one delivery?
Not based on that, sir, but based on history that we have all the first trimester losses. So cervical causes mostly second trimester losses. So that cause has been ruled out. And based on the ultrasonographic evidences which we have for this patient, she doesn't classify under any Mullerian anomalies or Asherman syndrome.
The question is very simple. She has gone to the term or preterm, 34 weeks.
That also.
That means the anatomical causes are ruled out.
Ruled out, yes.
There are no defects.
Definitely.
Congenital defect in the uterus. This is what we want to ask.
Okay, sir. As we didn't have any testing for the abortus in any of these pregnancy losses, we cannot comment on aneuploidy as one of the cause for the recurrent pregnancy loss. However, with a normal peritoneal karyotyping, we have ruled out translocations as one of the cause. Based on the blood investigations which we did for the patient, the blood sugar levels for the patient were found to be normal. Hence, we have ruled out diabetes mellitus as one of the cause. And as she is a non-case of hypothyroidism, we have included hypothyroidism as in one of our differentials. For the citing the worldwide literature, the testing for the inherited thrombophilias is not routinely recommended in recurrent pregnancy loss, as mostly it has seen a correlation with the second trimester miscarriages.
Why there should be abortion in hypothyroidism? How hypothyroidism causes the early abortions or abortions for that matter? Any obstetrics president? हाइपो में क्यों होता है और हाइपर में क्यों होता है? दोनों में होता है abortion.
Yes, sir.
What is the cause in hypothyroidism? What is the cause in hyperthyroidism? Yes, please. इम्प्लांटेशन फेलियर तो सब में ही होगा बेटा, तो मैं तो मैकेनिज्म पूछ रहा हूँ। हाइपो में बेटा ऑटोइम्यून डिसऑर्डर्स एसोसिएटेड होते हैं, ठीक है ना, दैट इज वाई शी इज हैविंग TSH ऑफ 71 है, एंड इन स्पाइट ऑफ थायरोक्सिन heavy dose 100 microgram, it is not being controlled. So in the hypothyroidism, most of the time cause is the autoimmunity, while in the hyperthyroidism it is the metabolic disturbance caused by the hyperthyroid or thyroid excess thyroid hormone. I think Rajiv Kasliwal is here. Dr. Rajiv, endocrine fellow है कोई? आप तो रेजिडेंट हैं, DM है? So that is important. And another thing which Dr. Rajiv Kasliwal told me only last week or about 2 weeks ago, that thyroxine hormone, all obstetricians must listen it, should be given early in the morning before taking anything, and after at least 1 hour you can take other medicines. It has to be taken on empty stomach. साथ में सारी दवाई एक साथ दे दी, इफेक्ट नहीं आएगा उसका, ठीक है ना। ये इम्पोर्टेंट चीज़ है कि थायरोक्सिन को जैसे सेमाग्लूटाइड को देते हैं, रेवल्सस को देते हैं, उसी तरह से इस मेडिसिन को भी पहले देना होता है, ठीक है। सो कॉज ऑफ हाइपो द mechanism for the hypothyroidism usually
autoantibodies.
It is coming already, so you can link it that also.
So we have excluded inherited thrombophilias as one of the cause. Now, based on the clinical history which we have for the patient, we have included antiphospholipid antibody syndrome as one of the cause for our recurrent pregnancy loss. And it suffices 2 of the clinical criteria of modified Sapporo. One being the more than 3 spontaneous consecutive losses, more than 3 spontaneous consecutive pregnancy losses of less than 10 weeks of gestation. Okay, and another being a history of preeclampsia in the previous pregnancy, for which she had to undergo a preterm delivery at less than 34 weeks. However, as she had presented to us with a conception, we could not test for the antiphospholipid antibodies. And lastly, more than 50% of the cases are still unexplained, which require further research and evaluation. So chronic endometritis has a role in recurrent pregnancy loss, but sorry sir,
he is asking whether tuberculosis is responsive.
TB, sir, tuberculosis, genital TB can cause Asherman syndrome, ultimately leading to infertility and recurrent pregnancy, implantation failure also.
कोई भी infection होगा, that will lead to inflammation. That may lead to the inflammation of the fetus, inflammation of the placenta, inflammation of the uterine or endometrium. So any infection for that matter. वो पूछ रहे हैं pregnancy losses के लिए. You are answering Asherman syndrome or infertility. So any active inflammation, whether it is bacterial, viral, parasitic or anything, active infection can lead to the
recurrent
pregnancy
losses. So to summarize the probable causes for our case, one is the hypothyroidism, another being the antiphospholipid antibody syndrome based on the clinical history which I just elaborated, and lastly being the unexplained cause. We referred to the patient to the Department of Endocrinology for further evaluation and workup of hypothyroidism, for which I would like to call Dr. Harmanpreet Singh, Senior Resident from the Department of Endocrine, to take this case further.
Thank you so much for inviting.
Any is on leave or what? No idea. And other faculty?
Sir, my senior is other faculty. Thank you, Smit, for inviting me. Good morning to all the dignitaries and faculty. I will be taking the case forward from here. So, patient is a known case of hypothyroid since 2013, and she is taking 100 mcg per day. So, she presented to Department of Endocrinology at 8 weeks of gestation, and her TSH was found to be raised, which was 71.12. So, anticipating this, we sent anti-TPO antibodies, which was also raised, which was 419.4. So, we need to understand before that thyroid hormones, that it is necessary for the brain development and the neurocognitive development. It is advisable prior to conception that hyperthyroid females should achieve a near normal target of TSH. But since we see this patient has came on the 8 weeks of gestation, her TSH is high, which is 71. So we increase her, anticipating this, we increase her dose to 200 mcg per day. That is 2 tablets of 100. Then we followed this patient on 10 weeks of gestation. Her TSH was again found to be 43.43. We took her history again. We found that she had a poor compliance and she was missing her doses daily. Despite, we continued on same dose 200 mcg per day. Then this patient presented on 20 weeks of gestation. Her TSH was 7.219. Improvement of TSH level was seen. But since we want her TSH to be near the normal target range, we increase her daily dose to 250 mcg per day. That is 2 tablets of 125 per day. Then on 26 weeks of gestation, her TSH was 2.86, which TSH was near to the normal target range. But we anticipated that in each trimester the fetus grows, the mother weight grows, so the need for the thyroxine increases. So we further increase it to be 250 mcg per day from Monday to Saturday and 375 mcg on Sunday. Then this patient presented on 30 weeks of gestation. Her TSH was 1.35. It was in the normal zone, but we still wanted her TSH to be in the normal range. So we further increased to 250 mcg from Monday to Friday and 375 from Saturday to Sunday.
Also normal range.
Yes, sir. But sir, we as the trimester is going, the patient is coming the third trimester. We wanted her for the neurodevelopmental growth. The weight will be increasing of the fetus and the mother's weight. So we wanted to anticipate earlier that it will the TSH will increase. So we anticipate earlier. So TSH target as per 2017 ATA guidelines. In the trimester 1, the TSH range is 0.1 to 2.5. In the second trimester, the TSH range is 0.2 to 3, and in third trimester is 0.3 to 3. So we need to understand that two types of hypothyroidism: overt or subclinical. Overt is where the TSH is increased and the FT4 is decreased. Subclinical is where we have TSH increased and normal FT4. So now the treatment guidelines as per ATA 2017. If the TSH is above 10, we will always treat. If TSH is between 4 to 10, we will treat regardless of anti-TPO status. If TSH is between 2.5 to 4, we will treat only if TPO is positive. So these are the complications of the thyroid disorders in pregnancy. It is seen that in the overt hyperthyroidism versus subclinical, miscarriages are more severe and more common in overt hyperthyroidism, and neurodevelopmental delays are frequently seen in the fetal.
Now to look at the trimester-wise management for this patient. In the first trimester, apart from the oral folic acid supplementation, we had started her on vaginal progesterone 400 milligrams once daily, and including antiphospholipid antibody syndrome as one of the cause for our case, we had started her on empirical tablet aspirin 75 milligram once daily and the injection enoxaparin 40 milligrams subcutaneously once daily. And the thyroxine supplementation was as advised by the endocrinologist. In the second trimester, the same management was continued. Oral iron and calcium supplementation was started. Vaginal progesterone was continued till 20 weeks of gestation. And in third trimester, the same management was continued, and the oral aspirin 75 milligrams was continued till 34 weeks of gestation, and enoxaparin subcutaneously was continued until delivery. She was given a prophylactic steroid coverage with injection dexamethasone for fetal lung maturity at 32 weeks of gestation. Ultimately, with the patient's mental resilience, our sound clinical judgment, despite 9 losses in her 11th pregnancy, she was able to reach 37 weeks of gestation and underwent an elective lower segment cesarean section, for which she delivered a male child of 3.5 kgs with a Apgar of 8 and 9. The baby handed over to the neonatologist immediately after birth, wherein the baby was tested for the TSH on day 1 of life, reported as 6.792. Baby was handed over to the mother's side immediately postpartum. Post-operative period for the patient was uneventful with a normal lactation. LSCS stitch line upon discharge was healthy and she was discharged on post-operative day 5. Was advised to follow up for wound care and contraceptive counseling. Thyroxine dosage was reduced as per endocrinologist and was advised repeat thyroid profile assessment after 6 weeks and was also advised APLA testing after 6 weeks. Now I would like to call Dr. Sarika Yadav to throw some light on the genetic causes for the recurrent pregnancy losses.
Good morning all. Thank you, Dr. Smith. So genetic factors constitute 2 to 5% cases of recurrent pregnancy losses. If we look at the causes of first trimester losses, 50% are chromosomally abnormal. So they are mostly numerical. That is a change. There is a change in the number of chromosomes. So it can be increase in number, which is known as trisomy, or it can be decrease in number, which is monosomy, or there can be an extra set of chromosomes which are known as polyploidies. Risk of miscarriage. Aneuploidy is change in the number of chromosomes. So like most common aneuploidy is trisomy 21. So in the 21st chromosome, instead of 2 homologous chromosomes, there are 3. So another are monosomies where there is a decrease in number of chromosomes. Risk of miscarriages from chromosomal abnormalities increases with advancing age as the oocyte quality decreases with advancing age. Looking at the parental causes of recurrent pregnancy losses, they are balanced translocations, which means translocations means there is an exchange of chromosomal material or DNA between 2 different chromosomes. So they can be reciprocal translocations or they can be Robertsonian translocation when it occurs between acrocentric chromosomes, that is 13, 14, 15, 21 and 22. There can be sex chromosomal mosaicism or chromosomal inversions. So the test which needs to be offered in patients of RPL is, if we have a decent viable product of conception, it is chromosomal microarray, which is sent in normal saline with 1 or 2 drops of antibiotic to prevent any contamination. If the result comes to be aneuploid, that is, there is a change in the number of chromosomes, that means that aneuploidy has caused that abortion. So we do not need that we have found the answer and we do not need actually any other workup. If it's euploid, that means the number of chromosomes is normal, so we can say that genetics is not the cause of that abortion. If there is any unbalanced chromosomal translocation detected on the microarray, then we need to offer the parent a parental karyotype to know the origin of that translocation, whether it is inherited or it is a de novo, so that we can prognosticate the further outcomes and give a pregnancy plan for these kind of patients. Other tests which are also available are karyotype, fluorescent in situ hybridization, but due to clear advantage of chromosomal microarray in the current era, we are not offering these tests any longer. So if a couple is having an abnormal parental karyotype, suppose there is a translocation, the future options for these patients can be, they can plan for a spontaneous conception. There is a 50 to 60% chance of a live successful outcome even trying for a spontaneous conception. They can go with IVF, pre-implantation genetic testing for that particular chromosomal rearrangement and transferring of only the healthy embryo, or they can also opt for a gamete donation. Couples should be informed that even if a parental abnormality is found after karyotyping, the cumulative live birth rates and chance of a healthy child are good despite a high risk of subsequent pregnancy loss, which is around 30%. So in this patient, the karyotype was normal, so we had ruled out genetic cause. Testing of thrombophilia could not be done because of her pregnancy state. But to discuss the causes of thrombophilias and RPL, I would like to invite Dr. Vaishali from Hematology department to take the case further. Thank you.
So coming to thrombophilia are of 2 types, as in inherited and acquired. Inherited causes include factor 5, that is Leiden mutation, prothrombin mutation, methylene tetrahydrofolate reductase enzyme mutation, protein C, protein S and antithrombin deficiency. Acquired causes include antiphospholipid antibody syndrome. So according to European Society of Human Reproduction and Embryology guidelines, for women with recurrent pregnancy loss, they recommend screening for antiphospholipid antibodies, that is lupus anticoagulant, anticardiolipin antibody after 2 pregnancy losses. So for Antiphospholipid antibody syndrome, European Alliance of Association of Rheumatology has suggested a criteria in 2023 which has 7 domains. So domain 1 is macrovascular, which includes venous thromboembolism. It could be pulmonary embolism, deep vein thrombosis, renal vein thrombosis, cerebral venous thrombosis, retinal vein thrombosis. Domain 2 is also macrovascular, arterial thrombosis, that is coronary artery thrombosis, peripheral splanchnic renal artery thrombosis, stroke and organ infarcts. Domain 3 is microvascular, which includes livedoid vasculopathy, apial nephropathy, pulmonary hemorrhage, adrenal hemorrhage. Obstetric domain is domain 4, which includes more than 3 consecutive losses at less than 10 weeks or fetal death less than 16 weeks. Fetal death with preeclampsia, placental insufficiency with severe features, severe preeclampsia or severe placental insufficiency at less than 34 weeks, severe placental insufficiency or severe placental insufficiency at less than 34 weeks. Domain 5 includes any cardiac valve thickening or vegetation. Domain 6 is for hematology, that is thrombocytopenia, platelets between 20,000 and 1,30,000. Domain 7, to bring your attention, all the 6 domains are clinical criteria domains. The 7th domain is lab criteria domain, which is the APL domain. Lupus anticoagulant positivity, one-time or persistent. Anticardiolipin and anti-beta-2 GP1 positivity, which could be IgM only or there could be presence of IgG. To classify as antiphospholipid syndrome, there should be equal to or more than 3 clinical criteria and equal to or more than 3 lab domains. To take this discussion further, I would like to call Dr. Anshul ma'am.
Thank you, Dr. Vaishali. So before I take the discussion ahead, let me tell you, why did we choose this case? It was a challenging case for us because the patient had presented with uncontrolled hypothyroidism right from the beginning of the pregnancy. There was no proper RPL workup available, and by the time she presented to us, she was already 8 weeks pregnant, and we really wanted to give her a live baby. So the uncontrolled hypothyroidism was well optimized by the endocrinologist of our institute, and as she had no proper RPL workup available, we started her on empirical treatment using tablet aspirin 75 mg and injection enoxaparin 40 mg subcutaneously once daily, along with the progesterone support. Other than this, at the time of discharge, we thoroughly counseled her up for follow-up. Now let us see what is the role of progesterone supplementation in such cases. Progesterone is to be started 2 days after ovulation and is continued until 10 to 12 weeks after confirmation of the pregnancy. 2 formulations are available. One is natural micronized progesterone. It is given as 400 mg per day per vaginally till 20 weeks of gestation. It helps by inducing secretory changes in endometrium, and it is which is essential for the endometrial maturation, stabilization and embryo implantation. It has a very important immunomodulatory role to play. It induces shift from pro-inflammatory cytokine response to anti-inflammatory cytokine response. The other one is the dydrogesterone, which is given in dose of 10 mg twice daily till 20 weeks of pregnancy. It also has immunomodulatory properties. It decreases pro-inflammatory and increases anti-inflammatory cytokines in early pregnancy. A brief about the management of antiphospholipid antibody syndrome. The goal of management is,
apart from what you have said, immune role, protective role, immunomodulatory role and other stabilization role, progesterone has a very significant role.
uterine quiescent.
Yes, relaxation, and that must be mentioned.
Yes. The goal of management in antiphospholipid antibody syndrome is to reduce the maternal and perinatal risk and to improve the pregnancy outcome. Its medical management includes low-dose aspirin and heparin. Low-dose aspirin helps by blocking the conversion of arachidonic acid to thromboxane A2, and thus it reduces platelet aggregation and vasoconstriction. Thereby, it causes a beneficial effect on implantation. It is given in the dose of 75 mg to 150 mg once daily and is started as soon as the pregnancy is confirmed, or even we can start preconceptionally as well. It is discontinued at 34 weeks of gestation or at least 1 week prior to the planned delivery. Heparin, when given in combination with aspirin, it improves pregnancy outcome by 80%. It prevents venous and arterial thrombotic episodes and is started as soon as fetal cardiac activity is confirmed on USG. It is to be stopped 12 hours prior to the planned delivery. Again, two formulations are available, the unfractionated heparin and the low molecular weight heparin. We prefer the low molecular weight heparin because of its single daily dosing regimen, and the monitoring routinely is not recommended with it. Also, the adverse effects are very rarely noted with this kind. Let us quickly go through what the guidelines has to say for the management of recurrent pregnancy loss. As we have already discussed, the recurrent miscarriage is defined as 3 or more pregnancy losses. Both the RCOG and the ASHRAE guidelines recommend cytogenetic testing to be offered to all the pregnancy tissue of the third and subsequent miscarriages and any of the second trimester miscarriage. If the pregnancy tissue is not available for testing, parenteral peripheral blood karyotyping should be offered to the couple. They recommend for the assessment of uterine anomalies using 3D USG. Thyroid function and thyroid peroxidase antibodies should be tested. The couple should be advised for lifestyle modification to maintain a healthy BMI between 19 to 25 kg per meter square. The patient should be asked to stop smoking and to limit her alcohol and caffeine consumption.
Why should she ask to stop smoking and alcohol?
So it causes FGR and placentation problems. It causes the carbon monoxide.
What is the mechanism of action?
So the carbon monoxide actually causes the exchange of gases and
कोई विटामिन डेफिशिएंसी होती है इससे स्मोकिंग और अल्कोहल से?
Is it?
अरे
No idea. Has to be vitamin K.
विटामिन अल्कोहल से विटामिन B6 है, विटामिन 9 फोलिक एसिड है, विटामिन B12 है, which are responsible for the DNA synthesis and other things.
Yes, sir.
That is why they say that you stop all. आप तो ऊंची ऊंची बातें कर रहे हो, इम्पोर्टेंट चीज पे आओ ना.
The luteal phase defect testing is not recommended, but progesterone supplementation should be considered in women with recurrent miscarriage who present with bleeding in early pregnancy. Various studies and the published literature supports the role of progesterone supplementation. This is a meta-analysis published in 2019 in Cochrane database. They also upholds for the role of progesterone in preventing miscarriage in women with recurrent pregnancy loss. Again, in 2021, they published a systemic review which further encouraged for the role of vaginal formulation of progesterone, and they concluded that vaginal micronized progesterone increases the live birth rate for women with recurrent pregnancy loss and those who present with early pregnancy bleeding. APLA testing is recommended in all patients of recurrent pregnancy loss. However, inherited thrombophilia testing is not recommended. All APLA positive patients should be offered treatment with aspirin along with heparin from the date of positive pregnancy test until at least 34 weeks of gestation. Again, the published literature supports the role of aspirin in combination with heparin for the women with unexplained recurrent pregnancy loss, and the conclusion drawn is that the low dose, low molecular weight heparin and aspirin, when used in combination, it prevents recurrent miscarriage in unexplained and idiopathic cases with or without thrombophilias, and it seems to be effective in increasing the live birth rates. Now let us see what the Indian guidelines has to say. FOXY 2024 recommendation states that approximately 5% of the women suffer from recurrent pregnancy loss, and out of this 50% of cases are unexplained. Vaginal bleeding before 24 weeks of gestation is a risk factor for pregnancy loss, and progesterone supplementation in women with recurrent pregnancy loss has been found to increase the live birth. So, the take-home message is recurrent pregnancy loss should be evaluated in the interconceptional period. Multidisciplinary approach is required in managing such cases. Further research is required to explain the 50% unexplained recurrent pregnancy loss, and obviously tender loving and care definitely makes a difference. We extend our sincere gratitude to the management, MGUMST,